I've been leading on that work at a national level for close to 5 years at NHS England. Okay, so I'll start off. So, in terms of, you will have, I think, already heard some of this in your previous talks this morning, but the 4 strategic purposes of integrated care services, obviously we want to do all of these things, and I think for the first time, the NHS has always been very ambitious in terms of what it wants to deliver on. I think for the more so than any other time, it's become so apparent that place-based care is so essential. So by covering these particular ways of working in the long-term plan, there's a really strong vision for how we can improve the health of our whole population in a really preventative way, how we can tackle some of those issues that relate to the treatment gap, and certainly in mental health you'll know there's an enormous treatment gap of people who already have mental health conditions but can't get, the waiting lists are too long. Obviously COVID has really done 2 things. One, it's increased the number of people coming through and needing mental health services, and 2, it's absolutely increased our kind of waiting lists as well in terms of at the very severe end of the spectrum, because we've just not been able to provide the right level of care with COVID taking over. And when we think then about the long-term plan and all these priorities, what I'm going to talk about today, which is mental health rehabilitation, covers off quite a few of these, and it's absolutely relevant that if we support what is the most complex group, the 20% of people in secondary mental health care services who are the most complex, then we can really improve the whole system. And obviously it's the right thing to do for those individuals, and we release efficiencies by doing that also. So what is mental health rehabilitation? It really is thinking in a very personalised way, taking a whole system approach and getting people back who've got severe mental health issues and a lot of comorbidities back into their lives, back into society and in the community, and sustaining them there wherever possible. So when we think about this cohort, around 85% of them have psychosis as their primary diagnosis, and they really have the longer-term psychosis. They haven't had one episode and gone better. It's a long-term issue for them. And often when they come to rehabilitation, they may have been in the system and had psychosis for 10, 15, 20 years upwards. Okay? And it's very variable in terms of how people come into rehab in terms of that time at the moment, and that's some of what we're trying to standardise, because we know outcomes are better when you get in them earlier with rehabilitation. But many of the group have a lot of comorbidities. They have a secondary mental health condition of all kinds, and they also often have a long-term physical health condition as well, which complicates their care, because of course they totally are they totally impact on one another. So if somebody's mental health is deteriorating, they're less able to look after physical health, which then deteriorates, and vice versa. We see the impact. So we really have to be very kind of holistic in the way we support this group of people. A lot of people with what we call negative symptoms. So that's symptoms where they are not able to necessarily socialise as much. They, in terms of being able to plan and follow through, that sort of higher executive functioning can often be affected as well in terms of cognitive impairments alongside the negative symptoms of withdrawal, etc. And a lot of them also really need a lot of support in the community or in the hospital setting around activities of daily living, getting up, washed, dressed, managing things like finances, shopping for food, all of those things. Because as a result of their mental health condition. So we're really kind of rehabilitating them in that sense, very practical sense, as well as thinking about mental health, physical health, and their social elements. And often people don't really want to engage. And when I was saying earlier about people often come to us after they've been in mental health services, secondary mental health services for many years, sometimes they haven't always got the right care for periods of time, which means they don't engage that well. So it's really, we have to make sure we spend a lot of time engaging people, meeting them exactly where they are. And we have people in my multidisciplinary team in the community whose sole aim is to go out and build that therapeutic relationship. And it can be going out for a coffee, it can be helping them to do their shopping, whatever it is, because that then that foundation allows us to do all of the other more complex work that those individuals need in order to be rehabilitated and get to their sort of higher levels of functioning and greater levels of independence. And although we do have good early intervention services now, there's a real gap, in terms of the number of people who need the early intervention services and the number who are getting it in a timely enough fashion. But even when people do get early intervention services, there's still a proportion, around 15%, the evidence shows, who still require this longer-term, ongoing rehabilitation. So it's really important to understand, because I think often people can have a shorter-term mindset, but there is this population who need that longer-term, ongoing care, and we forget them at our peril, really. Okay. So, how many of you know about the Getting It Right First Time programme? Good. Oh, that's great. Good number of you. Okay. So just to very briefly say, for the people who have not heard about it before, it's a national programme. It's really a huge quality improvement programme based at NHS England and Improvement. Started off by Tim Briggs, orthopaedic surgeon, and he realised that lots of orthopaedic surgeons practice very differently. There's no real standards about, well, when do you do a first hip operation? When do you do a knee revision? Which prosthesis do you use? All these kinds of, standards, I guess, weren't really translated into practice. So what he did, gathered the data all around the country from everywhere that did orthopaedic surgery in the NHS initially, benchmarked it all nationally, and then every single trust had this benchmark data, so they could see how they did on their infection rates, on their lengths of stay, on their people needing revisions, all of it. So powerful, because it allowed people to pick out where the good practice was, and it allowed us to see where the unwarranted variation was as well. Did so well, saved money, improved outcomes, and to the point where he went back, and the then Chief Medical Officer, National Medical Director, Bruce Keogh, said, well, you've got to do this across more. So more surgical pathways followed, then medical, and we have 3 now in mental health. And one of them is the mental health rehabilitation pathway. So that's what we've done. We've got all the data together, and we started, unfortunately, from a very low baseline in mental health rehab, but we've been able to go out to the trusts. I think we've been out to 48, the 52 in total. Not everybody engaged fully with the programme, but we pretty much got everybody. And we were able to do exactly that. So some of the information that came to light was the spend. We knew about it, but not really with kind of hard data, because surprisingly, it's not collated at a national level regularly. So when we looked at the data, you can see here that at the very top, at the very top line, we talk a lot. Who hears a lot about acute inpatient beds? Yeah, so we talk about it a lot. We talk about it every day, don't we? All day, every day. Okay. And we spend just over, it's $1 billion, per year. And when we look now, go down to the rehab beds, we spend about 560, so 55% of the spend that we spend on acute inpatients for psychiatry. We definitely don't spend 55% of the time talking about rehab. It's probably about 5%. Okay, so it just does not compute. And what happens is, so first of all, just to say that this is also, in terms of the long-term plan, there's money attached for the first time since the asylums closed, there's money actually attached to develop rehab services. And you can see in the line there with the community models for adults with serious mental illness that in total there is around, well, for the whole of the LTP for mental health, about £1 billion. So money is coming into to rehab. We've finally got the nice guidance for complex psychosis commissioned, and we've also got the GIRFT work, and CQC very much on board as well because of some of the problems that have arisen. And the key thing here with rehab is that you have to have this whole system approach. You can't just think about inpatients because, of course, if you don't support people in the community or get them out into the community, then they get stuck at different parts of the system. And that's often at much higher cost and much more restrictive, so they're in inpatient settings. And just as an average, for one inpatient rehab nationally, there are different bed types, but for a high dependency rehab admission, it's close to £500,000 for one episode of care per person. Okay, and if you get into the longer term beds, on average, you're coming up to around £800,000 per admission for one person for one episode of care. Okay, so these are significant sums of money. So we need to know, who we're spending them on, where we're spending them on, what are the outcomes and the experience for that person. Because often what's happening is, because we don't have the right community settings and enough of them, what's happening is that people get a really awful experience. They revolve in and out of hospital, they're neglected in the community, and they're sent way, way out of area. Many of you will have heard in different fora about people being sent out of area. You'll know about the safeguarding issues as well. We've seen some of those programs, all of us are horrific. People being out of sight and out of mind. Okay. This is the population who also die early from long-term physical health conditions because they're not, fully supported to really do something about their physical health. And they really need more tailored options around their physical health. Okay, and a lot of this is down, the majority of it, I think if you can stop people smoking with serious mental illness, will reduce a lot of this premature mortality, but not all. So community rehabilitation has a whole set of functions, and what we've been doing through the GIRFT work now and through the long-term plan, getting it into the long-term plan was really crucial, because now, whereas before about 50%, well, it depends what definition you use, between 25 and 50% of trusts around the country had community rehab services, so not all of them. And we know when people have specific community rehab services that people they get better outcomes. They get out of hospital, they stay out of hospital, they live in the community rather than being stuck for many, many years in hospitals and out of area. But now everybody, every trust through the long-term plan has to have this community rehab function as well. Some of this data, this is the benchmark data I was talking about. So you can see each of these bars, and we worked with NHS Benchmarking Network and others to create these and get the data together. Each of these trusts is spending, these are the bars that shows how much they're spending on acute patients in acute psychiatric wards per year. Okay, who are staying 3 months or longer. So generally, you say for an inpatient acute admission, you want people to stay not more than 30 days. 30 days is your kind of what you aim for. Again, huge variation in that. But you can see here, these are the numbers of people the amount that's being spent rather, for people staying 3 months or longer on the acute wards. You can see this trust on your far left, who's spending 30 million a year on keeping people who are there for 3 months or longer on the acute ward. The acute ward is not set up to do rehab. It's not set up to provide the kind of care that this cohort of people need. They're not all going to be that. There will be other people in there as well, but a lot of them, a significant proportion, are very likely to be rehab. So it's important then that we get that data so we understand where this cohort are around the whole system, and we think about their pathways and improve them. And here are the numbers of people out of area. And you saw on one of the previous slides, we're spending around 283 million per year on people who are out of area, away from their homes, their families. when they're in that setting, you know, one of their only roles is to be a patient because they don't have family visits. It's very hard for family to visit. They're not in their local communities, you know, all of that. So you're really kind of, it can really lead to a lengthening of people's recovery as well. Okay. Costs a lot of money. You can see here the NHS cost and then people who are out of provider placements in the red. Okay, so if you look at the second line, people might think, oh, well, we're spending this much in our rehab, but actually they're not. Their system, as a health system, is spending the second most amount. Okay, so we need to bring this data together as well across the system. ICSs help us to do that, so we can think about the cohort and what's best for them. Waiting times, we talked about people waiting on the acute beds, and they wait in different places, not getting the right care, poor experience for that person, and what happens is we're spending the money anyway in the wrong place. The other thing that happens is when you're taking up those beds, say an acute bed, a proportion of them in the CRISP report showed about 15% of people in acute beds actually need rehab of some kind, either in the community or they're waiting for a bed in a rehab setting. What happens, you displace then the people who need acute, and then you get more acute out of areas as well. So the whole system is interrelated, but not often thought of in that way. So the last thing I just want a couple of quick points so that we can finish. What we're seeing here, elective medical specialties and non-elective medical specialties, you can see that the England average for the general population, right down in the bottom, is 8.2% of people, the population, going into A&E, okay? And if you look then at the England average of rehab patients, it's much higher, it's 19.1%, okay? And then we looked by trust, and we could, again, you're showing the unwarranted variation, what can they do about it? When they're very high, who can they learn from, who's doing better? So we can move all the way upstream and give people, we're not going to bring that completely back to normal general population levels, but certainly there's a chunk of work that can be done that improves that journey into A&E and improves the person's experience and the costs as well that happen in that system. So one of the key things as well is thinking about supported accommodation. And a while ago, the Department of Health funded us to get this thematic review through the Royal College of Psychiatrists. And these are all things that the evidence shows that supported housing can deliver on. It can reduce hospital admissions, it can reduce the risks of tenancy breakdown. Often when tenancy breaks down, people either become homeless or they end up in hospital. Stopping people being stuck in hospital because they can come out and live in the community and the right level of support for them, and also stopping people going out of area. So actually, housing is a mental health intervention, and we're getting more and more integrated care systems really understanding that and think, okay, well, what is our housing complement? We need to know. Does it meet the criteria for our population? Because if not, they're just stuck in our hospital beds, and they're in the wrong place, not getting the right care. It's a really important part that the ICSs can come together around. And we have a whole, I'll share, the slides will be shared with all of you. We don't have time to go into this, and they're very detailed slides. But the national report, which can be found on the GERFT website, has used the evidence, has used all the data to give very clear recommendations that are going to be followed through. And there are three main themes: so eliminating outer provider placements, so keeping people local, using that data to improve quality and experience, and strengthening the partnership. So obviously all of these people actually own the recommendations, because this is who all of these different elements belong to, so it's so key. And we really see ICS as an opportunity to improve what happens and improve when we can bring people back into area, release that money, give that person better care and experience, better outcomes, and use that money elsewhere in the system. Okay, so If any of you are interested, these are my details, and we're providing local support through GERFT to really kind of improve on the on what's happening, sharing those best practice examples, and also helping people work through their particular plans, action plans. Then please do get in touch. So thanks for listening, and it's a great opportunity.